This is a case of LG, a 42-year-old man with a right transradial amputation secondary to a farming accident at the age of 16. His residual limb has extensive adherent scar tissue on the distal end and exaggerated bony prominences, which create a persistent challenge for comfortable prosthetic fit. He was originally fit with a body-powered prosthesis. Throughout his adult life, he has pursued a career in bookkeeping and accounting. His vocational interests included gardening and home maintenance projects. At the age of 42, LG developed a severe overuse and axillary impingement secondary to long-term use of the original prosthesis, which developed pain and mild swelling on the residual limb. LG went to rehabilitation for prosthetic fitting and therapeutic management for the swollen residual limb. He expressed a desire to move away from a harness prosthesis and reduce his painful symptoms. He was very interested in achieving a high level of bimanual function by incorporating an electric prosthesis into all activities of daily life, including vocational activities such as gardening and home maintenance tasks.
Background of the case. The causes of amputation in the upper extremity may be due to vascular disease or trauma. Vascular diseases may be the result of a systemic problem such as PVD, diabetes, arteriosclerosis, venous insufficiency, and so on. Trauma may be caused by compound fractures, blood vessel rupture, stab or gunshot injuries, compression injuries, severe burns, or cold injuries. The levels of upper extremity amputations include transcarpal, wrist disarticulation, transradial, elbow disarticulation, transhumeral, shoulder disarticulation, and forequarter. Men are more at risk when it comes to amputations related to trauma. It may be caused by work-related accidents such as machinery accidents or from motor vehicle accidents. The muscles of the forearm are divided into extrinsic and intrinsic muscles. The extrinsic muscles act to flex and extend the digits of the hand. The intrinsic muscles act to pronate or supinate the radius and ulna. There are 20 muscles of the forearm split into anterior or flexor and posterior or extensor compartments. Each of those compartments can be divided even further into superficial or deep compartments. The superficial compartment on the flexor surface of the forearm include the pronator teres, flexor carpi radialis longus, and palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis. The deep compartment of the flexor side of the forearm includes the flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. The muscles that reside in the superficial extensor compartment of the forearm include the brachioradialis, extensor carpi radialis brevis, extensor carpi radialis longus, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, and anconeus. The muscles that reside in the deep extensor compartment include the adductor pollicis longus, the extensor pollicis longus and brevis, extensor indicis, and the supinator. The biceps tendon attaches into the radial tuberosity. The nerves that supply this region are the median, radial, and ulnar nerves. A branch of the median nerve called the anterior interosseous nerve innervates the flexor pollicis longus and a part of the flexor digitorum profundus. The flexor pollicis longus and flexor digitorum profundus both contribute to grip force production and wrist flexion. A branch of the radial nerve called the posterior interosseous nerve innervates the supinator. Abductor pollicis longus and the extensor muscles such as the extensor digitorum communis. The extensor digitorum communis contributes to grip relaxation and wrist extension. In traumatic amputations, disease progression is abrupt. Primary complications include delayed wound healing, infections, vascular injuries, blood loss, and hypotension. Secondary complications include phantom limb pain, phantom sensation, heterotopic ossification, contractures, neck and back pain. In the patient's old prosthesis, LG found moderate function with the device but experience a lack of suspension, range of motion, stability, and comfort. These issues were hindrances for LG to achieve the full scope of his activities of daily living. The team suggests the patient would be fitted with a new prosthesis to address these issues. The proposed prosthesis would be a transradial myoelectric prosthesis that utilizes a TRAC, or a transradial anatomically contoured interface, self-suspending socket with a 3/4 modification to the elbow region. A clinical manifestation of a transradial amputee: there is pain on the residual limb due to severe overuse of old prosthesis, and swelling on the residual limb due to skin irritation.
Now talk about the bandaging technique that physical therapy should be using. So a 75 millimeter or 3-inch elastic bandage to be used so that he can perform a conical stamping procedure for the patient to compress and shape the residual limb in preparation for prosthetic prescription. Bandaging will also support the soft tissues and prevent formation of edema. Bandaging form derivatives are the circular bandaging for anchoring, figure of 8 bandaging to wrap the residual limb, and then spiral bandaging to wrap and secure the bandage. So let's talk about the precautions. So first and foremost, monitor the patient's feedback. Ask the patient if he feels any tingling sensation while applying the bandage, or is there numbness or any pain at all. Then another one is be mindful in applying the pressure, because too much pressure could impede the circulation of blood flow. And another one is application should be smooth with minimal to no wrinkles. Now let's talk about the pre-bandaging procedure. So before starting with the bandaging technique, the physical therapist will first assess the skin sensation of the residual limb using light touch, pressure, and pinprick assessment. Secondly, the physical therapist will check if there are wounds on the associated area of the residual limb. Thirdly, the physical therapist will clean the area before performing the stamping technique. So let's go to bandaging procedure. The bandaging procedure that we'll be using is a stamping technique. So the physical therapist will first ask the patient to extend the residual limb forward to be exposed for bandaging, and apply the bandage starting with the anterior to posterior of the residual limb. After doing so, make a circular anchor at the first point and the posterior portion to it to ensure it in place. And then make another turn on the front of the stump of the residual limb and repeat the anchor and turn until fully covered. Finally, make a spiral approach or a figure of 8 covering the sides of the residual limb with the same pressure on all sides, and secure the end with the use of a reflex tape. Ask the patient if the applied pressure is okay and what he or she is feeling. If not okay, reapply the bandage. So let's talk about the post-bandaging procedure. After performing the bandaging technique, the physical therapist will ask the patient if there are feeling of numbness, coldness, and tingling sensation on the bandage part. The physical therapist will check for the skin discoloration and formation of blisters. If so, reapply the bandage again. Prosthetic prescription. So Biomed transradial arm myoelectric prosthesis. So we use this because it provides efficient function for the activities of daily living. It minimizes swelling or buildup of mass in the residual limb by covering it. It promotes higher sensory feedback from the patient with the use of the EMG detector from the prosthesis, and to avoid any further damage from the residual limb from being exposed to the elements. It also maintains functional capacity of the limb.
Now let's move on to prosthetic management. Prosthetic management consists of 4 parts. Namely, they are pre-prosthetic examination, prosthetic prescription, prosthesis delivery, and prosthetic training. Let's first tackle pre-prosthetic examination. For the joint mobility, the physical therapy will perform range of motion using a goniometer on right upper extremity towards flexion and extension to determine the loss of motion of the right upper extremity. The physical therapy will then perform passive range of motion to assess if there are any abnormal end fields on the right upper extremity. For the anthropometrics, the physical therapy will use a tape measure to assess the length of the amputated right forearm in comparison to the normal limb, to provide a correct measurement in prosthetic prescription. The physical therapy will then perform limb girth measurement on the residual limb to measure the swelling of the residual limb. For the muscle function, the physical therapy will perform manual muscle testing on the shoulder flexors and extensors of the right upper extremity to assess the muscle strength and to determine the appropriate material for the prosthesis. As for the sensation, pinprick and light touch testing will be done on the right arm and elbow to assess the skin sensitivity of the patient and to avoid skin irritations when using a prosthesis. Let's now move on to the second part of the prosthetic management, which is the prosthetic prescription. Under prosthetic prescription is the analysis and evaluation of examination. This is done to provide a prosthesis that will help the patient with his avocational activities, and to address the need of the patient and provide the correct material to avoid skin problems when wearing the prescribed prosthesis. Next is the measuring of the prosthetic device. The physical therapy will measure the involved area to properly give the appropriate measurement for the prosthesis of the patient. The third part of the prosthetic management is the prosthesis delivery. For the prosthetic fitting, the patient is sitting on a chair while being fitted with the prescribed prosthesis, providing the correct measurement. Next is static examination. The physical therapy will assess the patient while standing using the prescribed prosthesis from maximal to minimal and to no assistance. Next is dynamic examination. The physical therapy will assess the patient inside parallel bars while walking with the prescribed prosthesis. The last part of the prosthetic management is the prosthetic training. Under prosthetic training are donning and doffing of the prosthesis, proper care, and patient education or instructions. For the donning and doffing, the physical therapy will educate the patient on how to properly wear and take off the prescribed prosthesis. As for the proper care, the physical therapy will educate the patient on how to properly take care of the prosthesis to avoid damage. The physical therapy will also tell the patient to keep the prosthesis dry and clean as much as possible. For the patient education and instruction, the physical therapy will tell the patient to elevate the wrist and hand above the level of the heart whenever possible. So this is what comprises the prosthetic management.
So, okay, we have the presentation of the Biomed Transradial Arm Myoelectric Prosthesis. For the first picture, we have here the graph. We have the 2D model for the second. And for the third picture, the finished product. So for the definition of terms, for the socket, so in this design, so a rigid inner socket is fabricated to fit the patient's residual limb, and the second outer wall is added, so designed to be the same length and contour as the opposite sound limb. So socket with the suspension cuff to allow to have a full range of motion. For the residual limb, so the term residual limb refers to the part of the body that remains after an amputation has been performed. For the EMG electrodes, so it measures muscle response or electrical activity in response to a nerve stimulation of the muscle. And for the EMG amplifiers, so the EMG amplifiers rejects interference while amplifying the EMG signal coming from the residual limb. For the battery, so the power source most commonly used for this myoelectric prosthesis is a 6 voltage nickel cadmium rechargeable battery, fully charged. So typically it takes about 12 hours to recharge a battery with a 50 milliampere charger. For the motors, so powerful Faulhaber small DC motors to ensure that the prosthesis can grip without any problems, so quickly and firmly and maintain a constant gripping forces. Lastly, for the electric hand, so this type of electric hand has a high gripping force, is very durable, and does not require a cosmetic glove. Okay, so that's all for the parts of our Biomed Transradial Arm Myoelectric Prosthesis.